This first talk is going to be on immune checkpoint inhibition in bladder cancer. These are my disclosures. I also root for the Mets, the Jets, and the Rangers. So just as an overview, we know that the immune system is constantly surveilling for foreign bodies, foreign objects, and cancer cells fall into that particular situation. They can make mutations that make them appear foreign to the immune system, and the T cells can recognize these particular antigens and attack these foreign cells. But cancer cells have learned to evade the immune system by this PD-1, PD-L1 interaction. And adaptive tumor expression of PD-L1 will shut the immune system off and then prevent any immune surveillance from going on. And as we see from this checkpoint where the tumor cell and the T cell interact, the PD-1, the PD-L1 axis gets blocked by some of the checkpoint inhibitors, and thus it's almost, in fact, it was funny, I got to do a piece on precision medicine with William Shatner as the interviewer, and I basically drew the analogy of the cloaking device that the Klingons used to prevent the Federation from seeing their ships. It's the same thing. You're basically unmasking that cloaking device with the PD-1, PD-L1 system and then allowing cells to die. So you're reactivating the immune system, and these engender a completely different set of side effects than what you would see with cytotoxic therapy. These are side effects predominantly of inflammation. Transaminitis from the liver, interstitial pneumonitis, rash, diarrhea from colitis, all these can occur and these can be treated, but the important thing, I'm not going to get into this talk, the important thing about immune-related side effects is that you have to recognize them early. So we have now 5 checkpoint inhibitors approved for the treatment of urothelial carcinoma. I can't give you a good explanation as to what, or at least a differential between one versus the other. We'll see some subtle differences from the clinical trial data, but there are differences in the approval pathway and where in the treatment algorithm they're approved. Atezolizumab, which is a PD-L1 inhibitor, and pembrolizumab, which is a PD-1 inhibitor. They're both approved for first-line cisplatin ineligible, and this was based upon accelerated approval at the same time in 2017. Atezolizumab was the first agent approved in May of 2016, followed by pembrolizumab, nivolumab, durvalumab, and avelumab. These are all in the second-line setting. So the only 2 agents that are approved for untreated patients are atezolizumab and pembrolizumab. And again, first-line cisplatin ineligible patients. So we've been doing a lot of work over the years trying to define medically unfit patients, and currently these are patients who have renal insufficiency, cardiac dysfunction, which preclude them from receiving cisplatin-based chemotherapy. Performance status can predispose to neutropenia, and this is a reason why you may not want to give these patients chemotherapy. And if you look at some of the trials, you'll see there's no consistent definition of what we say is unfit. In the past, our treatment goals have been palliation rather than cure, and we've used single agents rather than doublet agents, and now, of course, we have immune therapy for first-line treatment. So the IMvigor210 trial, we'll talk about this in 2 different cohorts. This is cohort 1, which were patients who were ineligible to receive cisplatin. They received atezolizumab at 1,200 milligrams every 3 weeks until clinical progression. These were patients who had no prior treatment for urothelial carcinoma, performance status of 0 to 2, and they were ineligible for cisplatin-based chemotherapy based upon their GFR, hearing loss, peripheral neuropathy, or their performance status. And as we see from the preliminary data from those patients, the 119 patients that were treated with atezolizumab, we see that there was no difference in the PD-L1 staining for those patients in terms of their overall outcome, but the objective response rate was 23%, and we saw a survival of about 15 months, which is comparable, actually better than what you would see with carboplatin-based chemotherapy in this particular situation. The Keynote-52 trial was almost similar in design, larger number of patients, 350 treated with pembrolizumab, slightly different entry criteria. They could have had class 3 congestive heart failure, grade 3 neuropathy, grade 2 neuropathy or worse, ECOG performance status of 2, or creatinine clearance of less than 60. And again, these were treated until progression or unacceptable toxicity. And again, we see a very, very similar objective response rate of 29%, a complete response rate of 7%, which is also comparable to patients who are treated with atezolizumab. And so this changed our thinking about chemotherapy in the frontline situation. This is what we're doing now for cisplatin-eligible patients, cisplatin chemotherapy followed by PD-L1 inhibitor, and then salvage therapy with a single agent afterwards. Now, in the past, for cisplatin-ineligible patients, first line was carboplatin-based chemotherapy, checkpoint inhibitors, and then single-agent chemotherapy. Now it's, and we'll see about an FDA warning in a moment, based upon the data with the FDA approval, checkpoint therapy with either pembro or atezo, and then chemo, and then single-agent therapy. And this was based upon comorbidity, not by biological markers. Well, recently, and again, this is a comparison of our data from what we mentioned before, overall survival similar between, actually higher in the atezolizumab group, not yet reported for pembrolizumab, but higher again than what we see with systemic chemotherapy. So does this now apply to all patients? The answer is no. The FDA came out with a warning in May of last year. Basically, this should be limited to those patients who only express PD-L1. So the PD-L1 low patients in a randomized trial that has not yet been released were found to have a decreased survival compared to cisplatin or carboplatin-based chemotherapy. So for these patients who are platinum ineligible, you should be testing PD-L1 status. And if they're low, they should get carboplatin-based chemotherapy. And if they're high, they should go on to checkpoint therapy. It's just a sequence. These patients, if they progress after carboplatin-based chemotherapy, will go on checkpoint inhibition therapy. Now, there are other trials that are now evaluating checkpoint therapy in combination with chemo. These are really most of them are about to mature. There's some that have a pure immune therapy. This is the Danube study, which is treating patients with either durva-tremi, durva alone, and comparing that to chemotherapy. So all of these are looking at combinations of chemotherapy with immune therapy versus chemotherapy alone, and the standard arms are gem, either carbo or cisplatin. So hopefully within the next year we'll find out whether these checkpoint agents can be moved up front for all patients in general, not just those patients who are platinum ineligible. Approvals for previously treated disease, as I mentioned before, there are 5 agents: atezolizumab, nivolumab, durvalumab, avelumab, and pembro. The approval for atezolizumab was based upon the IMvigor210 study. The second cohort of patients, those are patients who received prior platinum-based chemotherapy, 310 patients. This was an accelerated approval. And as we see from this particular trial, in contrast to what we saw with the platinum-ineligible data, there was a correlation between PD-L1 status and overall outcome. If you're PD-L1 high, you had a 48% chance of being alive at 12 months. It's about 30% if you're a PD-L1 low. And also the response rate was higher in those patients who had high levels of PD-L1 expression. Now, we recently, actually last year, we published our data looking at the 92 phase 1 patients who were treated with atezolizumab and the long-term survival data from these patients. And again, we see the same objective response rate and the break between PD-L1 positivity and negativity, 50% versus 17%. And when we looked at overall survival by PD-L1 status, again, we see a break between the two. But the interesting thing that we found when we looked at these patients on a long-term basis was the patients who tended to respond were patients with good performance status and also predominantly lymph node-only disease. The patients with hepatic metastases tended not to do as well as those patients who had non-visceral sites. So that actually, I think, is something that's going to become important in the future in designing our trials and selecting patients for checkpoint therapy. I think what was most telling from this trial is that we were able to treat patients for beyond 1 year. In fact, we start looking at the treatment-related adverse events. The majority of these occur within the first year of therapy. And as we see here, there's some patients going out to 3 years, and none of these patients develop grade 3 or 4 toxicity. And that's 20 patients out of the 95-patient cohort. So long-term treatment with these agents is possible. The problem is we don't know how long because, in fact, patients are often nervous about coming off of it because of the lack of side effects. Now, what about a phase 3 trial? This is where it gets a little bit sticky. The 211 study was a randomized trial, was performed predominantly in Europe, and the hypothesis was that you could take PD-L1 positive patients and see if those patients would have a better overall outcome. So this was a 3-layered study, and patients were randomized to receive either standard of care chemotherapy or atezolizumab. These are second-line patients. So the way this trial was designed is the primary endpoint was overall survival in the PD-L1 high patients, and if you hit that, then overall survival could be looked at in the PD-L1 positive patients, and then the intent to treat population. So if you missed on any of these particular endpoints, you could not go further down this particular pathway. This was designed to get this drug approved a little bit more rapidly. What was not included in this, or at least considered in this design, is the PD-L1 is probably both predictive as well as prognostic. So if we look at PD-L1 expression on tumor cells, it's predictive, it's prognostic for survival, it's predictive on the immune cells, and that's been seen from several different studies. So perhaps that's one of the reasons why this trial didn't show the difference. So this is the intent to treat from the IC23 patients. As you see here, there's no difference in survival, but what's kind of odd about this is that the chemotherapy arm had a survival of about 10 months. We generally see a survival of about 6 months in this group of patients. So right there, you've got something that's a little bit different in this patient population. If you look at the 1, 2, 3s, no difference. And unfortunately, the intent to treat, it was significantly different in favor of the atezolizumab. But again, you can't really make that conclusion based upon the design of the study. If you look by chemotherapy type, there does seem to be a superior survival compared to taxane-based chemotherapy. That's a pre-planned subgroup analysis. But again, there's something that is not, I think, a lot that needs to be explained from this trial. And I wouldn't basically make the conclusion that this is an inferior drug based upon this particular study. I'm going to go through this very, very rapidly because the data is very, very similar for each of these particular treatments. Nivolumab, 3 milligrams per kilogram, a open-label phase 2 trial, 270 patients, 8.74-month median survival, and again, about a 25% response rate. Durvalumab, when we look at 10 milligrams per kilogram given every other week, primary endpoint was safety and tolerability, and then response by RECIST criteria. We see an objective response rate of 18% in all patients, and we do see a definition based upon PD-L1 status. The patients who are PD-L1 high, of course, had a much better survival than those patients who are PD-L1 negative. This is, as I mentioned before, durvalumab is going into a randomized trial combined with a CTLA-4 inhibitor, tremelimumab, compared to chemotherapy or monotherapy. This trial hopefully will be out within the next year. Avelumab, same thing. Survival of 7.4 months, progression-free survival 1.5 months, and again, no difference in PD-L1 staining. But we do have phase 3 data which supports the use of checkpoint inhibition therapy as second-line treatment. This is the Keynote 45 trial, very similar in design, or at least in numbers, to the atezolizumab study. Pembro versus standard of care chemotherapy. More than 500 patients entered in this trial. They had to fail platinum-based chemo, and this trial did hit on its survival endpoint, 10.3 months versus 7.4 months at the median. But here, no difference in PFS, and this is a theme that we see with immune therapy across the board. We will see survival benefit, we'll see objective responses. This is due to the durability of the response to chemotherapy, to checkpoint inhibition therapy. You often can see patients from the swim lane plots survive quite a long period of time. So what are our future directions with IO in bladder cancer? Well, we heard the talks about non-muscle invasive disease previously, and this seems to be a great area to look at single-agent checkpoint therapy. These are studies are being done in BCG-resistant patients. In SWOG, we have an active trial looking at atezolizumab given every 3 weeks, and those patients are BCG-resistant. The only trial that has actually released data at this point is the Pembro trial that was presented by Ron DeWitt at the ESMO meeting this past fall. This is our SWOG study, taking BCG refractory patients, giving atezolizumab, doing repeat cystoscopies as well as biopsies to see if there's changes in PD-L1 expression. And maintenance is going to be given at 12 months and then surveillance for 18 months after the treatment is completed. The Keynote 57 trial looked at pembrolizumab in a very, very similar group of patients. The cohort that Ron presented was the cohort A of 130 patients with carcinoma in situ, with or without papillary disease, and they received pembrolizumab, and they were evaluated by cystoscopy and biopsy. And predominantly, these, of course, are male patients, good ECOG performance status. If we start looking at some of the tumor patterns, T1 disease with CIS was in about 12% of patients, CIS with high-grade TA, 15%, and carcinoma in situ alone was 74%. About 30% of patients had a high positive PD-L1 staining. This is very, very intriguing, but we need more follow-up because the complete response rate in this trial was reported as being 40%. So the question is, what's the durability of this? And also, again, in the short follow-up for the study, there's been no progression to T2 disease. So I think that these are the two parameters we have to look for, which is progression to T2 and what the durability response is, and then over time we'll see. Adding CTLA-4 in metastatic disease, which is another checkpoint in immune therapy, ipilimumab is an approved drug for melanoma. 10 patients who had progression of disease on nivolumab, 1 partial response. But it seems that if we move this dual combination therapy up front, that we may overall get a better objective response rate. This was an ESMO presentation by Dr. Rosenberg from Memorial, where he gave nivolumab at 3 milligrams per kilogram, nivolumab at 3 milligrams plus ipilimumab, or the flip, 1 milligram of nivolumab plus 3 milligrams of ipilimumab, and then they received nivolumab maintenance therapy. And there did seem to be a overall better survival in the lower dose of ipilimumab, the higher dose of nivolumab, compared to the other two different arms. So this really needs further confirmation. It seemed to be present in the overall population, those patients who received Nivo that seemed to overcome the inhibition, at least the dual checkpoint inhibition, and was best in those patients with PD-L1 high expression. Now, what about adjuvant therapy? We mentioned the need for this before. We don't have any standard adjuvant therapy post-cystectomy. There are 3 trials, 2 of which have completed accrual. 1 is currently accruing patients. Atezolizumab was being looked at post-operatively in muscle-invasive urothelial carcinoma. They had to have had T2 or greater disease at surgery if they had neoadjuvant chemotherapy, but if they had no neoadjuvant chemotherapy, T3 or higher. Primary endpoint is PFS. The nivolumab trial is basically taking all comers with muscle-invasive disease. Again, similar stratification, prior neoadjuvant chemotherapy for T2 or greater, and no neoadjuvant chemotherapy for T3 or greater. And then the trial is now going on right now in the intergroup in SWOG, as well as being led by formerly what was known as ECOG. It's all comers with muscle-invasive disease, no therapy of pembrolizumab. And so again, I would encourage people to enter patients on this study. It was mentioned in the previous talk that there are neoadjuvant studies that are going on right now. These are being both done as single-agent therapy as well as in combination. Giving Gem-Cis predominantly as a chemotherapy backbone to these patients. The primary endpoints of pathological complete response, which is thought to be related to overall survival. There's 1 pure immune therapy trial looking at durvalumab plus tremelimumab. It's being done for feasibility. This really would be maximal immune therapy. But again, when you combine checkpoints, you basically double the overall toxicity rates, and there have been toxic deaths reported with combinations of ipilimumab and nivolumab, so you've got to be careful about the patient population you administer this to. So these are some of the NCI trials, and again, single-agent studies or single-agent chemotherapy, single-agent again, and then IO-IO. In SWOG, we're also looking at a different way of handling immune therapy. There's something called the abscopal effect, where giving checkpoint therapy plus radiation therapy may be synergistic. So this study that's being led by Parmar Singh is looking at atezolizumab for 1 year, combined with radiation therapy and chemotherapy, and patients will be observed after this particular administration of chemotherapy and RT, and the primary endpoint is going to be overall survival. This is chemo-RT plus concomitant atezolizumab, and then adjuvant atezolizumab after that's completed. Just a quick note about biomarkers in our remaining time for this talk. I'll go over a couple of minutes because we've got a little bit of extra time. PD-L1 staining, you hear a lot about this. It's associated with a higher response rate and maybe linked to overall survival. But the problem is that there are multiple assays which look for PD-L1 staining. And these will look at both the immune cells and the tumor cells. So the SP142 is looking only at the lymphocytes, does not really pick up the immune cell, the tumor cells, but the SP263 and 22C3 antibodies will pick up both. And so that may be the reason why we see these discordances between different studies and different drugs when you're trying to look at PD-L1 expression. So you have to look at the individual levels of PD-L1 expression based upon the antibody that's used. And these are all FDA approved. The other thing that we found too with immune therapy in solid tumors is the fact that there is a correlation between the mutational burden of a tumor and their responses to immune therapy. So we see here melanoma, lung cancer, bladder cancer. These are the highest mutational rates, or tumors with the highest mutational rates. They can make antigens at a higher rate and then be recognized by the immune system as foreign. If you look down here, prostate cancer is much lower down the totem pole, and prostate cancer, as we'll see in our talk on Saturday, there's some responses with immune therapy, but it's not as robust as you would see with other tumor types. Now, when you start looking at the different subtypes, and we mentioned this in the previous talk before, mutational load in terms of the basal and the luminal, we start looking at these particular hotspots and the responders and non-responders. In the individual subtypes, we see that there's a higher response rate or tendency towards a higher response rate with higher levels of mutational burden. And in fact, when you start looking at mutational burden and PD-L1 status and do this in terms of a quartile analysis, the patients who do best are the ones who are PD-L1 high and have high mutational burden levels. And that's seen both with the platinum treated as well as the platinum ineligible patients. With atezolizumab, it seems that the patients who respond best to treatment are those who are luminal type 2s, and the basals are the ones that tend to respond better to chemotherapy. But the question is, we need to do a prospective trial to select these out. And again, this leads to the fact that the combinations may be the better way to go in this particular situation. So why is that? So when we start looking at the overall immune cell expression, the luminal type 1s are the ones that are the immune desert. They have low levels of T effector cells. The luminal type 2s are the ones that are inflamed, and they have low levels of stromal gene expression, which potentially could inhibit the immune cells. And then the basal tumors have high levels of the T effector cells and high stromal gene expression, and the stromal gene expression will inhibit the T cell effect. It's slightly different with nivolumab. It's more the luminal type 1s that cluster out with the higher responses. But again, this may be the difference between PD-1 and PD-L1. So in conclusion, checkpoint inhibition therapy demonstrates significant anti-tumor activity in urothelial carcinoma as initial therapy in cisplatin ineligible patients and in patients with cisplatin pretreated disease. Trials are ongoing to explore the immunotherapy-based combinations and using an early stage of disease, and we really need a better understanding of these markers to help sort out our patients and determine prognosis.